This does not have an effect on fertility from that point of view. And from the point of view of causing things like adhesions and so forth, again, that is not an issue with fibroid embolization. So for me, it is a viable treatment option, but again, it's about that multidisciplinary discussion and patient consent, informed consent.
Yeah, my comment on that, I would say the main problem with fertility is the available evidence, like the quality of evidence which is there. Is it something that we can rely on to actually say it's a viable option? Because probably the evidence is there is not a lot of it. Most patients who desire fertility have actually not been advised to actually take this treatment. So there are not a lot of studies in these patients to actually absolutely recommend it with confidence that it can be used. There are a few studies though which have been showing some probably confidence in terms of previously we were using it as an absolute contraindication, but probably there is some possibility that it can be considered, but I am not sure if there is very good evidence to recommend it upfront in these patients.
All right. According to the literature that I'm aware of, there's one randomized control trial which was done by Mara et al. Last 2008. That was the only RCT that was looking at the reproductive outcome comparing UAE versus myomectomy. And the conclusions of that particular study was that there was a better reproductive outcome in terms of pregnancy rates and live births following myomectomy and more miscarriages following UAE. Then, so they looked at people who actually had infertility and those who had desire for future fertility. We know that the majority of women with fibroids will conceive spontaneously without needing help, and they will have uncomplicated pregnancies. And we know that about 2 to 3% of possibly of women with infertility is just related to the fibroids. So I think most of the people with symptoms related to fibroids probably don't have infertility. They may desire to have children, but they do not have infertility factors. So I think the other studies I've seen, they have not explicitly stated that a patient had infertility. They have said had a desire for fertility. So I think those are two distinct groups. Someone with a future fertility desire and somebody with infertility. So maybe, I think that there is a lack of evidence, but we know there's one RCT which looked at people with infertility, a group to say they have some fertility. We showed a difference. So I don't know, I would think it would be good to have MDTs because we know infertility, it's important to do a full fertility evaluation to assess the male, to check the sperm count and any male-related issues, to check the female for several other causes, hormonal issues, etc., and then come up with the definitive plan related to fertility treatment. Also, there are some women who require assisted reproduction. So for example, I had a patient who was 40, in her 40s, I think 43 or 44, with severe male factor, sperm count 0 point something, sugar factor, and and fibroids. So we know that women who are to undergo IVF, if a couple is to undergo IVF, if we have fibroids which are distorted in the cavity, their chances of success are going to be reduced. So because of that mass effect within the cavity and the related inflammation and everything, maybe which is 40 or 42. So if we do, this is my understanding with embolization, that maybe the fibroids, it's smaller, but that mass effect is still there. So their definitive treatment is IVF, but we still have the mass effect that is not removed. So possibly, like just to say, it is important to have multidisciplinary management of patients with the responsible between the radiologist and the gynecologist, and then we inform our patient, and then of course with informed consent, the patient then decides whether to have a UAE or to have a mammectomy, knowing what is the full causes, like the whole holistic, what is really causing infertility and what is the best way forward for that particular patient.
And just to echo those sentiments, I think the multidisciplinary approach is key, particularly with the multifactorial issues like subfertility. I think it's absolutely key. And even with, in as far as the assessing patient for fibroid embolization, you gave the example of a nulliparous patient with a fibroid. You know, what's the size of the fibroid? What's the location? Is it pedunculated? Is it intracavitary? Is it cervical? All of these things make a very big difference in choosing the treatment option.
Thank you very much. I think the bottom line is you can't give a blind statement to a diagnosis without really evaluating the patient. And the good selection of patients is always good, bringing good results. You too can be part of this discussion. So I think it's all about selecting your patients and giving the proper management.
I am Said. I'm with Hospital Information Services. So my interest is mostly on patient blood management, focusing more on blood-based medicine. So the question that I have is on using UAE on PPH. We may identify patients that are high-risk PPH. What are the options and strategies that you would suggest to approach your services for these patients to benefit, because we can identify that they are already high risk to have PPH. And secondly, there will be times where the PPH happens as an emergency. What are your response times and how can we engage you and your services? Not just here, also in Harare, since it's happening all over the country. What are your plans of decentralizing your services so that many of our mothers can benefit? And also please include the costs.
Thank you very much. It was not yet time of questions for Dr. Chitora's presentation. It was a discussion on uterine artery embolization and fibroids, but maybe you can quickly answer that question. But let's try to focus on fibroids and uterine artery embolization.
So in essence, the touching in of bringing in PPH is more in the long-term view for us. We still need to get the work done in terms of the hardware and training to get the numbers up to that point. But it's just to say that once we've got the numbers and the hardware in place, it is another option for this situation, which is a big, an important situation for us. For the high-risk patients, you can actually plan these procedures electively. So an elective cesarean where you know that you're likely to have issues, catheters and balloons are put in place preemptively before the procedure starts. And if there are concerns, then the balloons are then inflated and so forth, or embolic applied. So this is a standard of care worldwide. But just because we are behind the curve on that doesn't mean we shouldn't aspire to get there.
Thank you for that. Maybe you can discuss more during lunch. Thank you.
All right, thank you. My question to both, or
to all the panelists is what is the cost implication of both procedures? I think it's a factor that we need to consider when we're counseling our patients. How much does it cost a patient to go through UAE versus myomectomy, be it laparoscopy or open, so that at least the patient gets a proper context, or when we are counseling our patients about both options, we can actually collectively give them information that is proper. And I think it would be good to emphasize also on the issue of who is the right person to discuss about UAE with the patient. Is it the gynecologist or the radiologist? If the patient goes for an MRI at Dr. Chatora's place, is the patient going to come back? Am I going to discuss UAE with the patient myself, or you won't see the patient back, Dr. Chatora takes over and discusses UAE, and the next thing you hear the patient say, finally, eventually, this is what happened to me. When I went for the MRI, it happened like this, and I eventually got UAE. Thanks.
So I'll touch on both questions. When it comes to the cost implication, the biggest cost implication for these procedures is the consumables, which we need to import. You're looking at your catheters, your wires, your embolic particles. The advantage that we've had is that our medical aid providers have bought into the concept. So for patients who are on medical insurance, it is something that the funders are covering. For the patients who are not, as cash-paying patients, I don't have the exact figures to hand, but you're looking at probably between $2,000 and $3,000, which includes all of the consumables and so forth. In as far as who is the right person to see this patient, like we said before, it's a multidisciplinary discussion. One of the things that I would like to highlight is, as a practice, we do not redirect anyone's patients. If a liver surgeon is to send a patient to us, who we believe would benefit from a biliary stent, we wouldn't then just drag the patient into our fluoroscopy suite for the biliary stent. We give clinically appropriate recommendations, but we do not redirect patients. So if there are any colleagues who are concerned that they may not see their patients again, rest assured. So again, in as far as who sees the patient, obviously the gynecologist sees the patient as the discussion. We are more than happy to see the patient in our clinic as well and give our recommendation for the patients to make an informed decision.
Thank you very much. Dr. Fanyana, are you satisfied? Do you think 2,000 for embolization is too much? How much is my myomectomy? Maybe I change the price for now. Right.
Okay, thank you. My question is to do with the blood flow to the uterus post-embolization. Maybe the panelists can touch on how embolization, this procedure, may affect the vasculature around the uterus, and if it could possibly have any adverse effects to especially the women that are trying to have babies. Will it affect carrying? Will it increase the risk of miscarriage, preterm labor, things like that? Thanks.
Yeah, thank you for that contribution. So we've also seen that some of the women, when you're now having to do assisted reproductive technology, we can then struggle with persistent thin endometrium and then associated reduction in implantation rates. Some women who are older, because fibroids obviously come with age, so you have the 40 or 42-year-old, and then after embolizations, remember some of the fibroids then pass down the vagina. So there is a study on hysteroscopy which showed that 6 months post-embolization, there is abnormal endometrium. So remember, we're talking specifically for fertility, patients with infertility issues needing fertility treatment. So for a 41 or 42-year-old, we've already eaten like 6 months or 1 year of their chance of getting fertility treatment, because we're having issues with the lining, still trying to work out to expel those fibroids, etc. There is, so essentially it's about endometrial dysfunction and myomictural dysfunction as well, affecting implantation, and the concern for potential of the preterm labor, PPH, etc. I know the data is here and there. Yeah. I think Dr. Jeff has a comment to say something.
Good afternoon. Thank you so much. I want to direct the question to the panelists. I'm a fan of local evidence. Since the work is being done, that we should have our own data to support what we are saying. And I'm also for pregnancy. So my question is directed to the pregnant to say, of the 196 that have been done so far, how many have experienced the pregnancy of these women, if there are any? Because I haven't seen any who has had the procedure yet. So I want to learn from those who have seen the post-UAE women. What were your experiences if you have seen them from the panelists and probably the floor? Thank you.
No, thank you, Dr. Maybe we'll allow Dr. Chatura to answer the two questions together.
Thank you very much. So the first question about affecting the pelvic circulation. Now I'll just draw us back to the first point that these procedures have been done for more than 4 decades now. And the techniques have been refined over time. And one of the clear understandings we have now is what constitutes the end point of the treatment, which is the point at which you have reduced the perfusion to the uterus enough for the fibroids to shrink, but not so much so that you then affect the normal uterine tissue and endometrial tissue. And our understanding of that has gotten much more refined in terms of the endpoint. So as far as I'm aware, when we look at the statistical data, there is no significant statistical, or there is no research that has shown that there is compromise to then the ladies then carrying pregnancy normally after fibroid embolization when they conceive. In terms of the ladies that we've seen, I don't have conclusive figures of how many actually desired to have pregnancy and then tried and went on to conceive. I do personally know of at least 4 who have conceived afterwards, but in terms of the full number of that 196, I can't say for sure how many have gone on to conceive. Because remember, a lot of the ladies that we see, we are not seeing them for subfertility, particularly in our setting. You have got ladies who have got torrential menorrhagia to the point of requiring persistent transfusions, iron supplementation and so forth, who are not good candidates for myomectomy because of diffuse fibroids or fibroids coexisting with adenomyosis, where their only option is a hysterectomy and they are not at the stage where they are prepared to have that. So like, it's not just about the subfertility patients.
Thank you very much. I just wanted to add another factor to what Ruby was talking about. She focused on the endometrium. I'm a bit concerned about the elder patients and also those patients with the borderline ovarian reserve. Wouldn't it be a little bit better, for example, if we can access the ovaries to at least harvest the eggs first and freeze them before you embark on embolization? Because you put up a slide that the reserve is not affected. Most of the time it is affected because you are affecting the blood flow to the uterus and probably also to the ovaries. Because low ovarian reserve patients are a nightmare for us to treat. Wouldn't it be better for us to harvest the eggs first, then you go ahead with your procedure?
Maybe I can comment on that. I know that there are some studies, but not of very high quality, where they showed that if the women are below 45 years, the AMH will probably not be affected by that treatment. But to come back to Dr. Ari's question in terms of how fertility is affected, there is at least one meta-analysis of about 10 studies, but most of them were randomized, were observational studies with only one randomized control trial, which showed that embolization was associated with pregnancy loss, about 35% versus 17%, which was about twice as much. But I have to emphasize, this is not a very high quality evidence, but that's what we have. It was also associated with increased risk of cesarean section, and other smaller complications. So I would say it's best to be very cautious in terms of offering this to those who desire fertility. And it's important to actually make the patient aware if they want to choose this kind of procedure and they actually desire fertility, they have to be aware of the potential challenges which are not firmly proved, but there are possibilities, and if they are to participate in it, it's best to be part of a study maybe, so that we can have more information on this.
Just to give you another point, there are quite a lot of women that are below 40 that have got low ovarian reserve.
Thank you. I think we are already eating into our eating time.
So while you're going for the next question, maybe if I can touch on, obviously, yes, for ladies with the borderline or concerning ovarian reserve, if harvesting the eggs is an option, I would definitely not have any objections to that. I think anything that can improve the chances of conceiving in the long run is a plus. As far as affecting the ovaries from embolization, one of the standard parts of the workup is angiography, either MRI or CT, to assess the supply to the uterus and ovaries. And we are specifically looking for those patients where there is cross-supply between the ovarian and the uterine arteries. So in those patients where there is definitely no cross-supply, and we're happy that there is no chance of us compromising the ovaries from embolization, it's only in those cases that we proceed.
Thank you very much.
I almost forgot, Dr. Fanyana had asked about the cost of the procedure. But then one of the studies that Dr. Chatora presented, which is the END trial, in about 10 years there was about 35%, you said 31%, but actually if we consider those who were treated, it was 35% hysterectomy within 10 years, which adds to the cost of the procedure. If someone, for example, they have embolization, then 10 years later or within 10 years, 35% end up with a hysterectomy. That adds to the cost as well.
So I think there was a slide where I touched on that and said, when you look at the cost comparison, by the time we get to the 5-year mark, when you factor in all of those things, the cost is now the same.
Thank you very much.
And the other thing, sorry, to interrupt, we're talking about a 10-year difference from the time that you have your embolization to then potentially needing a hysterectomy. If we're looking at a young executive or young productive female who does not have the capacity to take the downtime from a hysterectomy at a certain point, but is symptomatic, I believe it still is a viable option, even if she still then does need a hysterectomy some years down the line.
Thank you very much. I just wanted to check if we can infer outcomes from uterine artery ligation during cesarean section in terms of fertility and pregnancy outcome. I've been following a few cases that I've done, and fertility was preserved in all those cases. But I'm sure the circumstances are different. But I think we have a lot of local data that can be pursued with local people, where we followed women after uterine embolization for PPH, what the pregnancy outcome in the subsequent pregnancies were fertility issues. But then they are also young, the uterus anatomy is different, but I think we can infer. Thank you.
Should be the last one. I'm allowing you because she traveled all the way from.
Thank you very much. Dr. Chatora, I just wanted to ask about, as an indication for uterine artery embolization, would you offer it to someone who's had a failed hysterectomy due to adhesions, for fibroids, and then wanted to do a hysterectomy, but they have a frozen pelvis? In that case, would you recommend embolization as an option?
So barring any other contraindications, yes, they definitely would be a candidate, because those adhesions and so forth will not have affected the pelvic vascular anatomy, so they would still remain a candidate. But again, it still depends on where are the fibroids, what is their morphology and so forth. We still need to go through those steps.
Thank you very much.
Just to follow up to Dr. Maguire's comment. So this is somebody with no infertility and doing a Caesar because they have conceived. Then just to say, to ask how permanent are the spheres that we put for a UAE? Are they like permanently occluding that portion, or after a few months it opens up? If we put a suture, is it going to be permanent, or it will come off and then re-establish flow? So I think those are the things that we need to look at for us to be able to answer your comment.
Thank you very much. I think we can talk until dinner time, but those who are in the scientific committee should be getting ideas as to what topics can engage people the whole day. I think fibroids, whether should we do a laparoscopy, a mectomy, should we do a hysterectomy? I think those are the questions that we may actually design for the next CME, next one. But we definitely need a CME on how to manage fibroids. Embolization versus surgery, which one? Is it open? Is it laparoscopy? Minimally invasive, and all those things. I think we can talk, but unfortunately, all good things come to an end. And I think this will be the end of this session. Just a reminder that we have got beautiful abstracts here. We have our researchers who actually took time to make these posters. So when I was doing my diploma, this is the exercise on its own. To make a poster here, you have to have some special skills. So you have to make posters on your own. So please, this is hard work. It takes a lot of time. Take time to look at them, and they will really appreciate the hard work that they put into these posters. It's now lunchtime. We'll be back at 2 o'clock. Let's continue the discussion during lunch hour. Let's mingle and discuss these topics.